shared with all participants. There we go. It's official. It's recording, and so you'll get access to that for people joining today, and also the slides. We'll send that out to you as well as a PDF. So let's dive in. So this is a project that was funded about 4 years ago by the Canadian Institutes of Health Research, which is Canada's national funding agency for health-related research. And so we want to acknowledge them. And also all the members of our team. And this is the team when we began this work back in about 2017, 2018. And you probably won't get a chance to read all this, but this is quite a large group, including people from multiple parts of Canada. We also have a couple of researchers from Belgium and from the US. So we're really, really pleased. And I also just want to say I'm so appreciative to be part of this team. I'm obviously the only one sitting here in front of you today, but I represent the work that's been taking place with this marvelous group of individuals. So the main goal of this research project is to develop and test a set of quality indicators for palliative care in the community. So when we're thinking about these and where would they be used, where would they be applicable, it would be in home-based palliative care or community-based hospice, but we're not looking at quality indicators for the hospital, for instance, or long-term care. And we have sort of 4 main objectives. Now, for today, I'm going to focus on the first 3, partly in the sake of time, but also because we haven't really started on the 4th one. But we did just last week receive additional funding from CIHR. So we actually have additional funds to keep going with this, and we will start to address that last objective. So I'm going to sort of walk through today the first 3 objectives and how we began to sort of create these quality indicators and what does that look like. And then at the end, show you a little bit of data from across Canada to look at some of these indicators and some of the rates of these issues from the data that we have in multiple provinces and Yukon Territory. This is, and this will be in the slides. If you want to go and take a look at this, Dr. Mike Evans has done a wonderful video that's really about sort of quality improvement and quality assessment and why is it important. If you're interested in that bigger kind of topic, I would definitely recommend checking that out. Okay, so first, a small detour, because I need to tell you a little bit of background to this group known as Interrye. So Interrye is the name of an international not-for-profit group. There's about 135 researchers. I know that says 100, it changes all the time. It's probably even higher than 135 from 35 countries. And I'm an Interrye fellow, which means that I participate in the activities of this research group. We have annual meetings, and really Interrye's sort of main reason for being is to conduct research to develop and test and evaluate what are known as the Interrye or Rye instruments and various applications of those instruments. So they're standardized clinical assessment tools that are used in many parts of Canada and around the world. And I'll tell you a little bit more about the assessment as we get there. So these are the countries that are involved in some kind of Interrye activities. And as I mentioned, the numbers are growing all of the time. I practically would have to update this every few months. And we have quite a sizable group in Canada. I think we have about 17 or 18 Interrye fellows or Interrye researchers involved in this group. So let me tell you a little bit about one of these assessment tools. And I've got a screenshot here of the manual. So this one is called the Interrye Home Care Assessment. And it is used widely in Ontario and multiple other parts of Canada. Not coast to coast, but certainly many regions of Canada are using it as part of their standard clinical assessment for home care clients. It's got about 300 items, and you can see the key domains here. So it's meant to give you a snapshot of the person. What are all the key pieces that I need to know about this person, like their cognitive status, like their mood and psychosocial well-being, so that the assessor can put a plan of care into place. So the first reason to use one of these Interrye assessment tools is for that purpose, to get to know the person, understand that family situation, and put services in place. Then the cool thing is we can do things like what I'm doing, which is use those data for other purposes like quality indicators. So, to tell you a little bit about how this happens, and in Canada right now, we have about 2.8 million of these assessments, and then they all end up in a central spot. So, let me walk you through this. So, as I mentioned, the assessor would sit down with the person, oftentimes with the caregiver. So, if they have family or friends or a spouse that also provide care to them, and they would do this in the person's home with a laptop. So, you've got everything captured electronically about that person. Then that information gets kind of rolled up and stored for all of the clients that that assessor is seeing on their laptop. And then I'm simplifying this, of course. Eventually, all of those data from all of those assessors in different parts of Canada, the data all gets sent completely stripped of any identifier, so no names, no addresses, or anything like that. And they go to the University of Waterloo. Now, I'm at Laurier. University of Waterloo is literally just down the street. And the senior Interi fellow for Canada is at the University of Waterloo. So that's where the data go. And then these data sets, and they are massive, huge, big data sets, they're available to all of us, Interi researchers in Canada, and our students as well. So lots of master's and PhD students can access these data through that server. And you can be anywhere, and you can work from home and get in and access the data, which is pretty neat. Okay, so let's talk a little bit about quality indicators and what are they? Well, they tend to be quantitative values. You'll see that I often use I often express them as a percent of how often people experience some kind of a clinical issue or a problem. And they're for a group of people. So you don't usually ever use quality indicators for one person. Yes, we collect the data on each person with that assessment, but then we take all of those people and we put them together for, say, all of Ontario or all of Nova Scotia, or maybe a region of Ontario, because obviously Ontario is big. We get about 250,000 of these assessments annually just for Ontario alone. So the QIs are expressed for a group of people. And the other thing I want to point out is that they cannot tell you for sure if a provider or a region is providing poor quality of care. They point you towards what you might want to look at. Something just is a flag. So I've got a little picture down in the bottom corner of the check engine light in your car. So that's one way to sort of think of this. If you're like me, the check engine light comes on. I don't really know what the problem is. I mean, I really don't have a clue. You will never see me over on the side of the road with the hood up looking underneath, because it doesn't help me. I don't know what I'm doing. I do know something's wrong though. So I need to get the car into the mechanic. It's the same kind of thing. The quality indicators are a flag. They're an indicator of something, especially if it's something to be avoided, like excruciating pain, for instance, and your organization has a high rate. You want to ask some questions about why that is. But just because a provider has a high rate of something you want to avoid doesn't mean definitively that they're providing poor quality of care. That's important to remember. Okay, so Next up, how do we use these? Well, there's a lot of actually, there's a lot of different ways you can use quality indicators. So I'm just going to talk about a couple. For example, this is one organization. Let's say, a given organization wants to look at their quality over time, and they're focusing on percent of people experiencing pain. As they're a hospice palliative care organization, they want to get this down, and they want to look at how are we doing. So they might look at this over time, as I'm showing here. Break the year up into quarters, and let's look at the percent of people. And by the way, I just totally made this up. It's not real data. I just made it up to give you an example. And maybe you've implemented something maybe in the spring, and now you're wondering, are we doing something good? Does it seem like these rates are coming down? And based on these data, it does seem like the rate has gone from just over 10% down to about maybe 7%. So at that point, the organization can kind of make a decision, do we keep doing what we're doing? Do we try something different? It'd be part of the information driving their continuous quality improvement activities, as that organization's constantly asking, how are we doing? How can we do better? What should we change? Or is there something that's going really well and we should stay the course? So that's one way you could use the quality indicators. Another way is for different individual providers or organizations to compare themselves to each other. So that's what I'm showing here in this pretend example, where we've got these 4 organizations and they're all sharing their data in some way. And you can look at the percent of people who are experiencing pain over the course of, say, 1 year. Now, if you're in organization A, maybe you came into this thinking, we are doing a fantastic job. And I'm so pleased with how low our rate is of people who experience pain. But then you see this and you sort of go, well, wait a second. Organization D has their rate below 10%. I wonder what they're doing. So this is a way that the quality indicators, and this is sort of what we talk about as benchmarking, where you're sort of looking to see what's going on with your peers, who's doing what, and you might want to reach out to organization D or C and maybe have a conversation with them about what they're doing. Did they put something in place? Did they do some staff training? Have they got different pain specialists on their team? How is it that they've been able to get their rate down to half of what yours is in organization A? That's another way. And as I said, there's multiples of this, but in the sake of time, I thought I'd just talk about those 2. Okay, so now going through the objectives of our research. So the first one was to gather opinions from multiple stakeholders about what should be captured when measuring quality. Now, who are these stakeholders? Well, they're people who are receiving palliative care. They're people caring for those individuals. They're clinicians working in palliative care, and decision makers. So people working in health authorities, in regional health, what we used to have in Ontario's local health integration networks. But they're people who are in a position to make decisions about services, about programs, about funding. All of those people were of interest to us to speak to make sure that we understood what do those people think is important. So we began with a workshop in Toronto. We kept it in Toronto because of the potential costs of flying people across Canada. We couldn't afford a big meeting like that. So we kept it in Toronto to mostly individuals in Ontario. And we had a couple of brainstorming sessions over the course of a day to talk about, what do you think is important to measure? If we're going to create these quality indicators, what kinds of things should they measure for people in the community in a general sense, and also people who are getting home-based palliative care? We also did interviews and some focus groups with caregivers, with one patient, and with decision makers, those people working in an administrative capacity in palliative care in the community. And that was 20 different people. Most of those were interviews. We gave people the option. Do you want to do a one-on-one interview? Do you want to be part of a focus group? And for the people who were receiving palliative care and their caregivers, we also really wanted to understand, what do they think makes for good quality palliative care. So after the workshop, we had these kind of main themes. When you're looking at palliative care in the community, that circle in the center, what did people talk about? Well, they talked about supporting the caregiver, symptom management, access to care, and so on. And so this was sort of stage one, I would call it, the very first step in our work. And then, as I mentioned, we also did interviews with one patient. We tried very hard to get individuals with lived experience, but it was very difficult. So we had more caregivers of those individuals, and we transcribed all those interviews. And I just want to share a couple of things and some quotable quotes so you can hear their voice through this. So people talked about the potential negative impact of caregiving. And for example, I have to look at my notes here. One of the caregivers, Sam, said, "I know it sounds lovely and it sounds great and whatever, but I thought to myself, no one told you, me at least, or maybe society, the burden is basically going to be on you to deal with everything." And another caregiver named Helen, these are pseudonyms, by the way, we didn't use people's actual names here. "I'm also grieving my husband. I've been grieving him like I tell the children a long time because I'm losing him. I've lost him slowly," right? So because we heard this, how there can be this potential burden on caregivers, we looked at our data and we knew we could definitely have a QI that captures caregiver distress. And I'll show you some data. I think I've got that later. Boy, I shouldn't say that because now I can't remember, but I think I have some data on that later. Sometimes caregivers turned to emergency services when there were no alternatives. So Joan says, then there were all the calls for ambulances to get him to the hospital. I tried getting him there myself by taxi at first, but eventually I gave up and I started calling ambulances. So again, hearing that, and of course, these kinds of things were talked about by more than one person. We tried to find those key themes that a lot of people were mentioning. We were able to develop two different QIs with our Interrye assessment data. One that looks at emergency department visits and a separate one that looks at hospital admission. So people who are actually admitted overnight to the hospital. Okay, and then there was the importance of communication between the person, the family, and all these different healthcare professionals coming into the home. And Alice says, "I do think that it's really important sitting down at the beginning and just talking about what they can do, what my expectations were, and is it realistic? If not, what can we do? What's out there? What's available?" And we don't have data within the Interi instrument that picks up on these challenges with communication. So, what we did when we heard people talking about these things, we tried to link it with data that we have, and in some cases, we didn't have information on the assessment to capture that particular idea. And if you're interested in reading more about these interviews, there is an Ehospice article from April of last year if you want to check that out. Okay, so moving on to objective 2, which was to get feedback from experts on our early set of QIs. So after listening to people from the workshop, after going through all the interviews and analyzing what people said, we started to make a list of possible quality indicators that we knew people talked about, and or we've got data to capture this particular issue. So we ended up with a set of 27 preliminary QIs. And now this phase in objective 2 was to get a group of people to evaluate each of those QIs. So we had 21 experts from Canada, and Belgium and one from the US. And each person reviewed the list of 27 QIs very carefully. And we had them score the QIs in a number of different ways to decide, to help us decide, should we keep them? 27 is a lot. Most people in this line of work would probably say, 27 is probably too much. Well, how do you know which ones to keep and which ones to drop? Well, this was part of this expert panel, is to get them to weigh in, give them a score, so we would have some numeric values to try and sort out what they thought was the most important, and whether they thought we should get rid of some of them. So this is a list. I couldn't fit them all onto one slide. So this is a snapshot of the QIs, and you can see I've sort of broken them down into physical issues, things like pain, shortness of breath, nausea, vomiting, those kinds of physical signs and symptoms. Psychosocial issues, so we do have QIs to capture negative mood, so symptoms of depression, loneliness, and I put caregiver distress in that group. And then we have another group where I wasn't sure where to put these, but things like falls, hospital use, and advanced directives. So this is the not all of the 27, but just to give you an idea of what kinds of things we're able to create quality indicators from our data. Okay, so moving on to objective 3, which is, I think, some of the fun part, is to start to use these QIs and use the data that we have from across Canada and try and get a sense of, how often do these things occur? And is the rate kind of similar from one place to another? So QI development ideally is always this mix of input from people who are experiencing palliative care, receiving it, their caregivers, decision makers, clinicians. It's that combination of their input and the analysis piece. Because what you would like to see ideally is an indicator kind of is a bit different from place to place. So it gives us a sense of where quality of care might be different from one location to the next. Okay, so, I do have it. It's the first one. Excellent. I was pretty sure it was in here. Okay, so this is the prevalence of caregiver distress among seriously ill home care clients. So the reason that I'm calling them seriously ill and not palliative is we don't know for sure on this Interrye home care assessment. There is no item to check to say this person is receiving palliative care. But we have some other data elements that I can talk about if you're interested to flag what I would call seriously ill people. These are individuals who have, a prognosis less than 6 months, or they have some acute things going on that really does put them at risk of dying. And so you can see that this is written in a way, this QI, and they're all written like this, that a higher rate is not a good thing, right? This is prevalence of caregiver distress. So the caregiver during that assessment is expressing some distress about being in that role. So we're hoping to see low rates on these QIs. And you'll see right away, one of the first things is there's quite a bit of variation, right? If you look at Nova Scotia, they were the lowest at 16%, and the highest was Ontario at 48%. So these places are different. They're not all the same, and certainly some places have a higher rate than others. Now, I want to point out the little gray box there in the right-hand side. These have not been risk adjusted. Now, it's a statistical process that we use. It's a little bit technical. I won't go into too much detail here, but you can certainly ask if you're interested in hearing more about it. But basically what risk adjustment does is it tries to level the playing field. So for instance, you might say, well, I think that Ontario maybe sees more medically complex clients, Maybe these clients come into the home care program with a lot more difficulties and they need a lot more help, and no wonder their caregivers are feeling more distressed versus, say, Nova Scotia. So characteristics of those clients might be influencing this rate. It's not really about quality per se, it's just about the kinds of people that that home care program serves. The risk adjustment tries to get rid of that, but I'm noting here, we haven't done that yet. That's objective 4. So we haven't begun that whole risk adjustment piece. So I want you to take these with a grain of salt, maybe even more than a grain, maybe, you know, a bit more than a grain, because it's not necessarily comparing apples to apples at this point. But I wanted to give you some data just to give you a sense of, you know, what can we do? What kinds of things can we measure with these Interrye data? Okay, next one is, and I can't read it, prevalence of severe or excruciating pain, again, among those seriously ill home care clients. Okay, so now, slightly different picture. Who's lowest? You have to go to the other side on the West Coast. Now BC has the lowest rate, so lower is good. And the highest rate, well, we've got some ties. We have 21% in Manitoba, home care, Ontario, and Newfoundland and Labrador. So one of the first things we're noticing is across these different indicators, some places look better than others, and it's not even the same individuals or same providers that look the same. And we see this all the time. That is not unusual to see. And third one of these data is the prevalence of negative mood. So these are clients who are experiencing signs and symptoms of depression. They do not necessarily have a diagnosis of depression, but they are certainly experiencing tearfulness and crying and, you know, lacking interest in regular activities and those kinds of things that manifest among people who have depressive symptoms. And now we see back to Nova Scotia with the low of 16% and the high of 41% in Newfoundland and Labrador. So just from these three, and we have over 20 of them, we see something interesting popping up. Number one, I would say, is they're not all the same. These are all places using the exact same instrument. So we don't have to worry about, oh, well, the way Manitoba assesses pain and captures pain is a bit different from Ontario. No, they're all using that exact same Interrye home care assessment. So that can't be why we see differences, but we do see some differences. The other thing that's interesting, as I mentioned, is it's not always the same place who is the best. And in fact, when you have a group of 20 plus indicators, some regions will look good on some things and they'll look worse on others. And that's very natural. We have seen this before in the work that I've done on quality indicators just for home care, not for palliative or seriously ill clients. We see the exact same thing. It's really, really difficult for any one organization to do well on everything, right? They tend to have specific areas where they really shine and other areas where there's still some room for improvement. Okay, so what are the take-home messages here? What would I like you to take away from our conversations today? Well, I hope I've shown you how quality indicators can be really important to help us understand where improvements might be needed. And hopefully also you'll be cautious when thinking about, well, what do these indicators really mean? Is a high rate of caregiver distress in Ontario mean Ontario's not doing a good job? No, we can't say that. What we know is if Ontario is a bit higher than another place, it's food for thought. It's a bit of a flag. And then it's up to those providers to dig a bit deeper, to start asking some questions, to start looking at some other data that they have and comparing themselves maybe to other places to get a feel for what's happening and what might be contributing to this rate. And I think one of the most exciting things about this project, although it's not done, is that when these are finished, we'll be able to look at these quality indicators across Canada for starters, like I showed you today, but we'll have the risk adjustment piece in there. That's coming. But then we'll be able to compare Canada to other countries. So just for example, this home care instrument, the Interrye home care assessment, is used in, I think it's 22 countries around the world. So not only can we look at data across Canada, which is very important because we really don't have a set of sort of standard quality indicators for palliative care in Canada, we'll also be able to start comparing Canada to New Zealand, Canada to Belgium, Canada to the United States, and so on. So thank you so much for your attention today. My email will be there with the slides, so please feel free to email at any point, and I'm also happy to take any questions.
All right, there had been one question that you had addressed briefly in your presentation, but one question from Antonio was why only one patient was involved in the first round. And you mentioned that you had encountered some issues with recruiting people with lived experience. Did you want to maybe expand a bit on that, on what those particular challenges were?
Yeah, and I have to say, we have, so on that team of people that I showed in one of the earlier slides, we have knowledge users, which are people who are expected at the end of the day to be able to take this information and really kind of put it into practice. We have knowledge users from Yukon, from BC, actually multiple sites in BC, from Ontario, from Nova Scotia, and they helped us to try and recruit people with lived experience, people who were right then receiving palliative care. So we worked with them for a little over a year to try and find people who were willing to talk to us and do an interview. But clearly these people are very ill. So we tried very hard to find individuals who were receiving palliative care. We tried for about a year across different parts of Canada. And at some point we had to sort of say, okay, we need to move on. So that's why we only had the one person. Yeah.
All right. Well, for Antonio expressed, thanks for an excellent presentation. CIHR money well spent.
Oh, thank you.
And Jane also had a question about whether it's possible to have a copy of the assessment.
Oh, unfortunately, I cannot just give it to you, Jane. I wish I could, because it's copyrighted. So you can buy the manual if you go to the Interrye website, interrye.org. There's a spot there where you can purchase either like an e-copy that you can just look at on your screen, or you can purchase a hard copy. That way, if you want to get your hands on the manual, so the manual has the assessment itself with all the questions, and then how you're to score each of the questions. Interi, I will tell you, because we get these questions all the time. People are like, can I just see it? And I'm like, I can't just send it to you because it's copyrighted. So Interi is working on an electronic version that you can go and look at and browse, but not download or print or that sort of thing. So it's coming. I'm sorry to say that I can't just send it to you, but you could get it from the website, from buying a manual. Yeah.
And we also have another question from Brian asking if an organization could get their own data for analysis.
Yeah, I mean, any organization that's using the Interrye data has at their fingertips roughly 300 pieces of information about each of these individuals. So absolutely, it would just come down to having someone who's in that position to do the analysis. And by and large, these quality indicators, they're very basic. You know, they have a numerator and they have the denominator. And the math isn't really tricky. So if an organization was using one of these Interrye instruments, there's also a palliative care instrument for Interrye, they could absolutely generate these QIs. And I maybe wasn't clear at the beginning, but our goal, so when this is all done, maybe, hopefully, fingers crossed, about 3 years from now, the quality indicators will be in the software. So right now, if you're in a nursing home in Ontario, a long-term care facility in Ontario, it's mandated that you use the Interrye tool for long-term care. And those organizations can generate the quality indicators with pointing and clicking. They're all embedded in the software. So we're hoping that that will be the case here as well someday, a little bit down the road.
All right, perfect. And we also, so we have a few questions here. You maybe touched on it briefly with any similar work for inpatient or outpatient seen in hospital or hospice-based programs as opposed to home-based?
Yeah, not right now. The Interrye instruments, just taking Ontario for an example, are mostly used in home care, including palliative home care, long-term care, complex continuing care, and inpatient mental health. And there's some use in other sectors, but the Interrye tools have really not made a big splash in acute care in Ontario. The folks in Australia are actually ahead of us in that game. They have multiple different kinds of Interrye tools in their acute hospital settings. And we're just not there yet. I'm sure we would all like to see some more, Interrye tools built into local hospitals, but that's not the case yet. Maybe someday.
All right, that touches as well on another question that had come in about a plan for QI for acute care. So that kind of touches on that question as well, where it seems like there's the appetite for it doesn't seem to have been there, even though there could be. We've seen that application in other countries. So that's a very interesting point. So thank you. It answers a question that we hadn't even gotten around to asking yet. Perfect. And another question that we had was about looking at the different cultures across Canada as a factor in some of the responses, like the contrasting culture between rural Newfoundland and Labrador versus downtown Toronto.
Yeah, great question. So I think we'll be able to do some work with that because for the most part, we do get some kind of regional identifier. So for instance, Ontario used to be split up into, local health integration networks. Some provinces have regional health authorities, and we do get that information, I think, for most places. I can't say if we get it for every single province and Yukon, but we don't get the full postal code where you could even drill down, even within Toronto, you could drill down further. So we are limited because the data have been de-identified. So you don't get the full postal code, but I think we might get the forward sortation area, the first three. Don't quote me on that. I have to look into it. We haven't started to slice and dice the data in that kind of way, but that's an excellent idea, and I can imagine we'll see quite some fascinating differences as you even start to go a little bit deeper in the data analysis.
Thank you. That's it's fascinating to see all the data that's available and the different ways that it could potentially be interpreted, and all of the opportunities for analysis and for learnings based on the data that's being collected. So thank you. And if anyone else has any questions, you can ask them either in the question and answer box or in the chat as well. We're monitoring both. Just from personal curiosity, what has been the most unexpected finding that you've had so far, Dawn? I know that from a researcher's perspective, you always end up finding things that you weren't expecting. Is there anything like that that you might be interested in sharing?
Because I'm not a qualitative researcher by training, so typically we think of research as being qualitative or quantitative, right? You either are kind of doing interviews or focus groups with people. That's not really my forte. I'm learning as I go because it is fascinating, and there's all kinds of things that you can see or hear maybe when you speak to people. So not being a qualitative person, I was very interested in this process, and I read through a lot of those transcripts from the interviews. And some of those transcripts were 30 or 40 pages long because we actually type verbatim exactly what people say. And I can tell you in all honesty, I laughed, I cried. The highs were high and the lows were very low. And I came away from that process and all of this work really over the last 4 years or so, being a little bit surprised at just the complexity and the messiness of this world. And if you want to get it right, you really do need to talk to a lot of different people. There's a lot of points of view. There's a lot of data. And I'm so glad that we did those interviews, because just hearing people talk about their own experiences and what it was like for them, and what the most difficult things were, what the biggest challenges were. I don't have any real personal experience with it. That was a real eye opener for me, and in a good way, because it just helped to educate me about what do people go through, and what are the good things, and what are the negative things.
That's lovely. Yeah, that seems to be a common thread, at least in my experience in my work so far with CHPCA, is the absolute crucial aspect of storytelling in this world, because these are deeply complex and deeply personal stories and experiences that people are going through. And so it's great to hear that that component is actively being considered in the research, in the data, because it is so important to people's experiences. So that's lovely to hear that that's being reflected as well. I do want to make sure that people have the opportunity to ask any further questions. We haven't seen any come in. If is there anything else that you want to add, Dawn? Maybe a call to action, or something that whether it's for participation in the program, or for types of data that maybe you're hoping to evaluate in the future. Is there anything else that you want to add to close before we wrap everything up?
I think it's what I'm hopeful for, which is that having this set of indicators that can be used, and we're purposefully designing them so you don't have to collect any other information. They're embedded within the information that's already collected. My hope is that this is going to raise some awareness to people about ways to use their data, and in ways that they maybe had never thought of before. And in particular, to address people who have serious life-limiting illnesses. And I'm a firm believer that we really have to try and get it right. When people are very ill or dying, it's just so vital to get it right, and to do the best possible job that we can. So I guess it's a bit of a call to action. And my hopes for the future is that once these are available and people can start using them, and maybe start to get excited about what they can do with their data, it will help to sort of shift that culture to raising awareness about these issues. And like I showed you, it's not 2 or 3% of people who are experiencing this. It's 20%, it's 40%. It's a lot of individuals who are seriously ill, or have a short prognosis, and they're dealing with all of these complicated psychosocial and physical issues. So just helping people to see how often do these things happen, and then we can start talking about, okay, what are we going to do about it? What's the next step in terms of quality improvement?
Yeah, definitely echoed in a comment from Queenie saying it would be good to raise awareness within palliative care, that within that it's important to collect data to advocate for those patients and for funding. One question she had as well was, how do you bring that awareness? How would you do that to bring awareness for students that are looking into going into this field?
Yeah, well, certainly. I'm very interested in taking on graduate and undergraduate students. So I actually have, at any one time, I usually have about 3 or 4 people that I'm supervising that are working with me. And I actually have an undergraduate student who's doing her thesis right now on a bad death. And what is that? What does that look like? Other committee with a student. Oh, my camera seems to have done something weird. Oh, well, I'm on a committee with a student at McMaster, and she's actually using these quality indicators to look at quality pre and post COVID. So there, to the extent that I can, I'm very interested in supervising students and being on grad student committees where we're trying to, get in and use these Interrye data and really make the best use of them that we can.
Mm-hmm. No, that's great. That's it's lovely. I know that in my experience with in my schooling, it's always been, oh, this data is available, and just knowing that it's available and knowing what possibilities there are for that analysis, for learning more, is always really interesting. And it always kind of, as a student myself at the time, I always got very jazzed about it. So that's great to hear that you're working with students that are interested in these data. Another question from Brian. HPCO has been collecting performance metrics in palliative care since 2017. Have these been explored by your group?
Not to date, although I know of their work and they certainly know of me. We have worked together. They were actually very instrumental in helping us to try and find caregivers and clients in Ontario to interview. So we haven't sat down and kind of, swapped perspectives from that point of view, but I do know of the work they're doing. And right now in hospice, there's some pilot studies going on using the Interi palliative care assessment, but we really don't have much data at all, unfortunately, for hospice. Maybe someday, I'm hopeful that people might be interested. Of course, you need an assessment that's much, much shorter than this one for home care. But we can't really generate data for hospice clients for quality indicators until we have more data. So maybe someday down the road.
Great. And another question from Bev was why there was some missing data from some of the provinces and territories.
Oh, yeah. So it just reflects the nature of the fact that this assessment is it's totally up to those regions whether they want to use it in a mandated, sort of government mandated way, like the home care tool in Ontario, or not. So we would love to see more coast to coast to coast coverage with the Interrye tools, but it really depends on that particular region or province and what they're already using, and are they interested in kind of looking at the Interrye tools. And of course, Interrye tools cover many healthcare settings, so it is meant to be sort of an integrated suite. So there certainly are some pretty neat things you can do when you have Interrye data from different places, but it's really it's up to them. We're always open. The doors are open. You have my email, even though I don't work with all of the Interrye tools. I certainly would be more than happy to help facilitate if some group was thinking, well, I'd like to maybe kind of try out this home care thing, or maybe look at the, doing some pilot testing with one of these Interrye tools. Please reach out. If I don't have the answer, I'll point you to someone who does, or I'll go and get it. But we're very excited about these instruments. We'd love to see much wider use of them.
All right. Thank you, Dawn. Yeah, there's always a need for more data on more Canadian data on palliative care. That's one thing that our team at CHPC is always trying to get more data available, make more data that's Canadian specific or region specific available for us to know more about what this landscape looks like. So it's great work that you're doing. So thank you for all of your hard work. Thank you for a lovely presentation. I think we can wrap up a few minutes early, and if people have back-to-back meetings, then they can have a minute to stand up and stretch and do maybe some chair yoga before their next meeting gets started. But on behalf of CHPCA, thank you so much, Don, for coming on and for sharing your presentation and sharing your learnings about your the research that you're doing on such an important topic. So thank you very much. And we will be sharing the recording with everyone who registered for the webinar by email in the coming days, as well as the slides. So you can expect that in your inbox within a few days. And we will hopefully see you at our next webinar.
Thank you. Thanks,
Right.
Kat.
Thank you. All right. Well, have a lovely day, everybody. And we will hopefully see you soon.